This is going to be topic 17.1, non-intubating airway management.
And after this chapter, you'll be able to understand the benefits of pre-oxygenation for any patient in the need of active airway management or ventilatory support, the use of cricoid pressure during manual ventilation, simple airway maneuvers that can make all the difference, understanding ventilatory pressure and reducing gastric inflation, indication and application of continuous positive airway pressure, and assessing the adult and pediatric patient for appropriate oxygenation and ventilation. So this is a general overview of basic airway management. It's a critical skill. The patient without an airway is a dead patient. This is figure 22.1, non-intubated airway management algorithm. And essentially, as we're looking at this, you assess the patient and you discover the need for airway and respiratory support. Pre-oxygenate, open the airway and attempt ventilation. Was that successful? If the answer is yes, then insert the airway and transport the patient. Answer no, reassess, reassesses provider, patient, and equipment. Insert airway, suction, see if there's an obstruction of any sort. Attempt ventilation successful. If yes, move about your business. If no, go on to the next one. Reconsider obstruction, suction performance, obstructed airway skills. Attempt ventilation, was it successful? If it was, great. If not, transport patient immediately emergently and consider requesting physician intercept. Very simply, this is with the basis. This is basic airway management. This is with the thought process that you do not have the ability to intubate. Basic airway management algorithm: pre-oxygenation and delivery devices. And in the pre-oxygenation, it should be like supplemental things, and we're going to look at those here in some pictures and talk about those: nasal cannula, non-rebreather mask, things like that. Equipment for basic airway management would be the basic airways, which are oropharyngeal and nasopharyngeal airways, a BVM, a barrier device, a pocket mask, manually triggered flow restriction, oxygen-powered ventilation devices, and this is a demand valve. And then various types of automated or automatic transport ventilators. And these are nasal cannula, which adds a considerable 0.5 to 6 liters per minute. That's what you can deliver via nasal cannula. And that might take them pretty close to 60% increase in the amount of FiO2 or the oxygen percentage. Figure 2.23, non-rebreather masks. Need to be able to look over these and be able to facilitate these in your clinical experiences. Non-rebreather mask can almost provide 100% through this reservoir bag. The bag has to be inflated prior to the patient actually breathing through it, though. And these are our basic airways, which are oropharyngeal or J-tube, and a nasopharyngeal. This is soft and pliable tube here. This is beveled. Be sure that bevel is inserted towards the septum of the patient's nose. Even if you can't insert it on that side, insert it any way you can, but then rotate it so that the bevel is towards the septum. And be sure to always use water-soluble lubricant with this. It makes it easier for the nasopharyngeal airway or NPA to go in. BVM assembly, bag valve mask device, barrier device, and this would be not quite a pocket mask, but this area here is for like bite block, and this will cover and protect you. One-way valves are generally implemented. This is an actual pocket mask where you can supplement via this oxygen tube the amount of oxygen delivery you're giving them. This is a demand valve, our flow restricted oxygen powered ventilation device, and we got to be careful with these. Please look at the rise and fall of the chest. Reason being is because we can overventilate them very easily. This is figure 2210, automated transport ventilator, and these kind of do the same thing as a demand valve, only the tidal volume allows you to set the tidal volume off of here, and then you secure the mask to the patient's face, and this would be by hand, so this would be by two-hand technique or CE fashion. We'll talk about that. Suctioning. A suction unit is essentially critical, and there's various types that are found on the ambulance. There are pre-hospital suction units that are available. They generally run off a battery. And then there's portable suction units. Pre-hospital suction units can be hand-powered, various different types, hand-powered, oxygen-powered, battery-powered, or wall-mounted vacuum units. Regardless of the type, the suction unit should be able to do the following, and that would be to generate 40 liters per minute of airflow through the tip and to provide a vacuum of 300 millimeters of mercury whenever the tubing is closed. And these are the various two. This is generally what we see for portable suction. There are some out there that are hand-powered as well. They work pretty well or fairly well. This runs off a battery device, and this is the same type that we see with the wall-mounted units as well. These are disposable. They can be disposed of in either way. So again, 40 liters per minute or 300 millimeters of mercury. Opening the airway, there's various techniques. Head tilt, chin lift is very simply, there's no trauma involved, and we're going to tilt back the head and tilt up the chin. And this would provide an opening of the airway. It kind of straightens out the tongue and allows air to flow over. Modified jaw thrust would be utilized on people with trauma. That's where you would actually pick up on the lower jaw area and push down on the upper maxilla area, and that would open up the airway, moves the tongue again off. And then the tongue jaw lift. Be careful with this one, especially if you have a seizure patient or something. You stick your finger in their mouth and they could seize and clamp down on your finger. So I'm always really careful at the point that I insert anything into the patient's mouth that belongs to me, like my fingers or thumb. Cricoid pressure, the Celix maneuver is what this is called. The American Heart Association has kind of gone away from this as far as the Celix maneuver goes. But the Celix maneuver is to provide a better look at the glottic opening. So by a downward pressure, and most people put their fingers on the wrong location, this technique allows the glottic opening to move downward so that if you're under laryngoscopy, you can possibly see it better. Advantages of this: consider the prevention of passive regurgitation and limit active emesis, and it may decrease gastric inflation during positive pressure ventilation. So this kind of works like the path of least resistance. After the lungs blow up, and what I mean by that is after they're ventilated appropriately or have decent rise of the chest, whatever's left over, if they're under pressure, will roll over into the esophagus. So we could pressurize their stomach or Taco Bell very easily with this. Limitations on this, on the Celix maneuver, can worsen the view of the vocal cords, does not completely eliminate the risk of aspiration, can lead to esophageal rupture. It can compromise an unstable cervical spinal injury, and may also cause laryngeal trauma. In pediatric patients, excessive force can occlude the trachea because of the cartilaginous rings that maintain the open trachea have not fully formed. So whenever we're doing it on a pediatric patient, very gentle should be our mantra on that. Face mask ventilation. Important concepts is the face mask interface, and very simply, it needs to have a good mask seal, and there are several ways to do that. We got a couple pictures on the next slide to kind of show you. Ventilation volume and airway pressure is essential as well. If the person weighs 500 pounds, you may have to provide a little bit more airway pressure, a little bit more strength in the BVM. Be sure you have a good mask seal. This isn't like a secured airway. Ventilation, volume, and airway pressure, we talked about that. Bag mask ventilations, you have to be sure that your ventilations are going in and that they're going in correctly. There's a couple ways to do this. We can use a two-person technique, which one person essentially isolates on the mask and be sure that it is sealed and the other person ventilates. Or we can do a CE method. Now that requires a big hand to do a CE method. So the C goes actually around the mask, and the E grabs the lower jaw and pulls it up into the mask. Then we can do pocket mask ventilation. You generally have quite a bit of force and probably get the best ventilations off of pocket mask ventilation, but it's not so automated and it ties one person completely up. Manually triggered flow restriction or manual triggered demand valve ventilations, or then we have automated transport ventilators. So this is the CE method, shown here in figure 2214, CE, pulling the lower jaw up into the mask and then providing pressure and a downward motion and ventilating, looking for equal rise and fall of the chest. And this is the 2-respirator version of that, where one person just ensures that you have a mask seal, pulling the chin up into the mask, and then the other person ventilating. This is an automated transport ventilator. Something similar to a demand valve. Demand valve would be a trigger on the top of this. So all of this stuff where you set the tidal volume and the rate, and there would just be a trigger. Once the trigger is depressed, airflow goes in. Now, this is under a considerable amount of pressure, so we should watch rise and fall of the chest. At the point that the chest rises equally, let off the trigger. Remember, any pressure that we have left over there will roll over into the stomach. Continuing ventilator care. Important concept, patient assessment. You have to continuously assess your patient. Immediately observe the patient, auscultate their lungs, measure their physiological signs, and monitor them closely. Prepare for transport. Gastric distension and failed ventilation. So at the point that we're blowing it over into the belly, we have to do something about that. Rethink, reassess yourself, and reevaluate to be sure that you are appropriately ventilating your patient, or you may need to think of something else. So whenever you reevaluate, the provider needs to examine the technique that's being used. The patient, do they have an open airway? What's their anatomical features? Is there any pathological features? The mask seal, is it correct? Equipment, be sure that you're familiar with the equipment. Masks, oxygen sources, and ventilators will be some of these. Oropharyngeal and nasopharyngeal airway placement. Suctioning. Whenever we suction, be sure that the suction unit is ready. Purpose of suctioning is to minimize the risk of aspiration and to prevent it, if possible. Rigid Yonker or tonsil tip suction devices should be utilized with the suction unit and inserted into the oral cavity. Obstructed airway management. There are a number of causes for airway obstruction, including epiglottitis, soft palate, foreign bodies, laryngoscope, laryngeal edema, airway trauma, just to name a few. Techniques for eliminating or opening an obstructed airway. In the conscious patient, we should use abdominal thrust. In the unconscious patient or infant, we should use back blows. The vomiting patient, we should use finger sweeps. If the patient still cannot be ventilated after suctioning, reposition, and obstructed airway skills have been applied, the patient must be transported rapidly. And again, this is in BLS mode, or basic airway management techniques. If you have the ability to bridge to ALS, then you should facilitate airway management under laryngoscopy. A nice set of McGills and a suction unit should probably be able to remove anything that is seen in the glottic opening. So this is figure 22.17 in your book. Normal and abnormal pulse oximetry waveform. Good waveform indicates adequate perfusion to produce an accurate numerical value. And the point of this is if you are having a good waveform, which is up here, you can see the pulse rise and come in there, and it's registering enough with the monitor, then very simply your assessment of this is pretty accurate. Now this is giving us hardly any waveform, and this would be the pulse ox. So I would not trust this information unless I got something consistent, or a consistent heart rate that would match what was on the EKG. Assisted ventilation. This augments the breaths that the patient is actually taking. Provides more effective respirations. Device most commonly used is a bag valve mask device. And timing is key. The easiest way to time that is to kind of turn up your oxygen, 15 liters per minute, place it on their face, and then as they are breathing, kind of coach them. So as they breathe in, and this will be shallow at first if they're breathing really fast, kind of assist their ventilation. Give them a couple more breaths and then kind of assist again. And then get to where you are assisting every ventilation and kind of go from there. You should be able to slow down the respirations at that point. The patient should be continuously assessed to be sure that they are breathing appropriately or having adequate ventilation. Continuous positive airway pressure. This assures in all phases of the respiratory cycle that the airway pressure is above zero. And what a CPAP does for us is this provides more oxygen pressure by blowing it into the airway. So never does a patient have an oxygen pressure of zero in the actual lungs. Combination of gas flow and resistant to exhalation. So we can actually turn up PEEP on most CPAP devices. So the air goes in and then it opens up the airways so we can recruit more alveolar space. Benefits of this are more airflow, improved oxygenation and ventilation, improved diffusion, and greater gas exchange on the surface area. Limitations are does not provide any kind of positive pressure ventilation, no difference in gas flow between inhalation and exhalation. The effects are limited to the alveolar and small airways, and CPAP has been used in various situations, including COPD, asthma, any kind of pulmonary edema at all, and it's relatively simple to use. And this is skill 22.1 in your book. And this is skill 22.1. Essentially assemble the equipment, and this would depend on which CPAP unit you actually had. Set the flow rate on the device per the manufacturer's recommendation or the protocol, and then apply the face mask to the patient and snug down the straps. Coach the patient to breathe with the mask and monitor and reassess the patient. Pediatric considerations in basic airway management. In general, techniques of the basic adult and pediatric airway management are the same. The differences are the anatomy and physiology. In a pediatric patient, the posterior occiput, or the back of their head, is significantly more prominent in the pediatric patient. Pediatric trachea is smaller and more susceptible to kinking. Nasal bridge of the pediatric patient is flatter. Ventilating the pediatric patient requires care to prevent overpressurization because their lung size is weight dependent as well. Pediatric patients are more susceptible to gastric inflation and are less able to tolerate it. So whenever we're looking at gastric inflation, this will actually put pressure and push up on the diaphragm, which is here, and thereby reduce the amount of airflow and ventilation that's actually coming into the chest. Pediatric patients generally suffer cardiac arrest secondary to respiratory arrest, as opposed to the adults who suffer primary cardiac arrest from living in the land of the chicken fried steak, or atherosclerotic plaques, heart disease, and so on. Conclusion. Tracheal intubation remains the gold standard of airway management. Basic airway management is the most critical and fundamental airway management the paramedic can perform. Knowledge and skill in basic airway management is mandatory. Expertise with a number of skills and devices allows the paramedic to ventilate patients through simple face mask techniques. The paramedic should advocate for the best possible care for his patients. Basic airway management is often just what the patient needs.
If you have any questions concerning this topic, feel free to contact me. My name is Roy Smith, or at SamaritanEMSOK.com or 405-492-8243. Thank you.